I think biomarkers are in great need in our field, and there was some very interesting data presented at the meeting around the Decipher score as a potential informative tool for triple therapy selection with a retrospective analysis of the STAMPEDE trial, specifically the arm comparing chemotherapy, docetaxel to ADT monotherapy. So not a direct resource from triple therapy data, but the researchers suggested that high Decipher scores prognosticated for improved response to chemotherapy. Do we think this level of data is strong enough to utilize Decipher as a potential tool to determine who should receive triple therapy?
So, I always, of course, this was a small number of samples that was tested, 160 out of a total of thousands. Obviously, what they could get their hands on, older samples. And they used a score. And, I like to be more granular than that. It might not require a score. It might boil down to just a few markers. Simple as Ki-67, which is embedded in the Decipher score, plus a couple of others. And this data was actually shown, but it is a good start. They had previously published some data with regard to proliferation index, plus minus a couple of other markers. I think it is upon us now, moving forward, to actually have a prospective validation, either of the score itself, if we want to make it simple, but why not, even if it's even more simple, something that we can do in our old pathology labs with a simple immunohistochemistry. Let's not take away from the great value of doing something simple and not costly within our own labs everywhere in the community, as long as we are able to have a validated assay. So I would vote for that, but we need to work together towards that. It's a start. It's a great start.
Yeah. I would say that we are way overdue for Oncotype DX for prostate cancer.
Oh, yeah.
Okay, and this Decipher data is maybe a start, but I don't know how much it supersedes Gleason score, for instance, or typically my application of Decipher has been for those intermediate risk patients where you're totally on the fence and there's a big spectrum of outcome. Here, this shows some inkling of being a predictive marker for chemotherapy benefit, and hopefully we can build on that with multiple other markers that have been individually reported, as SPOP, P10 being some examples, that tell us the biology of the disease and how aggressive it's going to be. So I think eventually it's a panel of biomarkers that will come together that will tell us whether to use chemo or not.
Yeah, I'd agree with what's been said. I mean, the data is intriguing, and it's great to see a molecular biomarker that actually looks like maybe it could be predictive. I'm not going to say it is right now, but the data sort of makes you ask that question. I think we just need prospective validation, to your point. There are trials being planned now that are looking at not testing triple therapy versus docetaxel, but triple therapy versus just an RP alone. I think that's the critical question. Can we use something like Decipher to figure out who needs triple therapy versus who gets by with just something like darolutamide or abiraterone added onto standard ADT? So hopefully with time we'll have answers to those questions. I think the other thing that really sort of was interesting to me was, they saw that you had high Decipher score in patients both with high volume disease, which is how we typically identify, patients we think need chemo, but also in the low volume patients too. So it sort of speaks to that being probably a more precise and better biomarker, but yeah, we got to do more data, more studies to sort of prove it.
It's what I mentioned earlier, that the volume is just a minute in time, and it's such a dynamic disease. You may be picking it up by accident early.
Biology is part of the story in terms of mediating volume, but it's not the whole thing. And Decipher actually starts getting at the biology, and that's what we really need.
Exactly. And yeah, prospective validation trials is really what we need, and those are big, expensive, hard studies to do, but
multi-institutional across the world.
But there's no way around it. So
well, also the bigger point is we don't have great surrogates or interim endpoints. If you're waiting for overall survival, obviously a good problem to have, because now we have to wait a decade or so follow up. But getting better surrogates that would give us that interim signal would also be an important thing.
Yeah. Well, excellent. So I'll open the question to the panel. Are there other studies from the ESMO meeting that you guys think warrant discussion?
Well, you're setting me up for trouble here. But I think we have to mention CONTACT-02. We got a
Yes.
final analysis.
Yeah.
It's a great study that's trying to introduce immunotherapy in combination with TKI, namely atezolizumab plus cabozantinib, in those men with metastatic CRPC that have that most aggressive phenotype, which was selected with clinical criteria. They did a great job about selecting such men. Everyone had already some concern about the control, because having selected for such an aggressive phenotype, you would like to see in the control potentially cytotoxic chemotherapy. But what we did is we went from abiraterone to enzalutamide. So these patients had been previously exposed to an enhanced androgen inhibitor. The data was presented earlier this year, was it, or last year, I believe? Earlier this year? Was
it was ASCO GU?
ASCO GU,
Yeah,
so earlier this year.
year.
It had some positive readouts to it that mainly had to do with men with liver metastases, the biggest unmet need, granted. And this presentation reaffirmed that if there is value, it is in a subset of patients. Are we ready to get it approved for those men with liver mets? We don't know. We hope the agency and the company are going to discuss it, and it will be one more thing that we have for these men. Is it enough to make us satisfied that, whoa, we have something now for these men? No, but we can give them some more hope for another treatment option. If I were to put my money on something that's, quote, not real money, but monopoly money, it would be looking at bites coming through, new agents that might be more addressing from the immunotherapy perspective. And I want to hear your thoughts on that and how enthusiastic you are with the data. Wouldn't put it down because it tackled a very difficult subject, but not as exciting as I would have liked.
I think one thing that the CONTACT-02 highlighted is that this patient population deserves to be addressed differently. And that most of these patients are a minority in a lot of our clinical trials. So that focusing on this big unmet need, dismal prognosis patient population is what I like about the study. And they obviously got a fair amount of patients who had measurable disease. You know, they were required to have measurable disease. What I don't like, and I agree with you, is that the lack of prior chemotherapy treatment. So in my management, am I likely to sequence this combination of cabozantinib and atezo prior to chemotherapy? I find it unlikely unless there is a patient who is specifically not a chemotherapy candidate.
Yeah, I agree with what everybody said. I think you know, the issue here is that in the patients who maybe benefit, again, subset analysis, that maybe benefit from this combination, they're the exact patients who really need chemotherapy. I mean, the men who've got liver metastasis, I would not feel comfortable using this. Now, if you want to redo a study to prospectively show that patients with liver mets benefit from this combo, probably in a post-taxane setting, I would welcome that. I think that's an important study and somebody should do it. Do I think it's going to happen? Probably not. But I'd like to see more data to actually prove that this combo actually has real benefit there. Because remember, we're seeing a slight progression-free survival advantage across the pre-specified study population and no OS benefit at all. So,
Well, you're essentially saying, I'm sorry, it should have been a physician's choice type of thing, like happened with the trial of rucaparib, for instance, where half the patients got docetaxel, and we deployed that.
That would have been more reasonable, yeah. I mean, I think that you probably still would be, you know, asking the question, because if I recall, I think the subset with liver metastasis was like 20% of the overall study. So it's a small subset. I mean, so it's tough because you've got a sort of a post hoc analysis where you're seeing maybe a signal there, but that alone is not enough to change practice. You need to have prospective data with predefined endpoints in the population of interest to actually prove it helps.
I mean, I would argue, though, that the chemotherapy outcomes in this patient population is also very dismal.
Oh, yeah.
There's no
Absolutely.
basis really for chemotherapy specifically
And that-
either in this
Absolutely,
population.
and that's why we need studies, right?
Yes.
And you're
Yeah.
right. We need to have trials
So-
that are geared towards these high-risk patients to figure out how to treat them better. It's an unmet need for sure.
And we need additional options, which maybe this combination provides, and that we don't have currently.
Absolutely.
Yeah. And the other point I think that needs to be made is that I think toxicity profile needs to be respected, and although
course.
the presentation from yesterday highlighted upon it, I think those of us that manage kidney cancer with cabo as monotherapy or with nivolumab understand that this is not an easy tolerated drug for a lot of patients. And for men who have often symptoms from their cancer, diminished performance status, to add on another agent that's going to detract from their quality, we really need to have firm data to support that's warranted.
Yeah, the lack of myelosuppression is attractive, though, compared to
That's correct,
chemotherapy,
yeah.
because a lot of our patients with really diffuse bone metastases, even marrow metastases, have a tough time with blood counts.
I hope and wish that they will show us also some molecular data, because you want to
Yes.
tease out which
I
are the
agree.
DDRs within these patients, kind of try to
That makes
potentially,
sense.
that would be wonderful.
Perfect, yes.
That would give them a beeline to where they need to be. I hope so.
That's a great point.